Welcome back. My name is Larry Shulman. I'm a medical oncologist here, and I do a little bit of global medicine as well, global cancer medicine. I have the privilege to introduce Dr. Yong Kim, who's our keynote speaker. I've known Jim now for 3 decades. Those years go by fast. And you can read his biography in there, but there are a couple of things I wanted to mention. First, when I first knew Jim, he and Paul Farmer had co-founded the NGO Partners in Health and truly developed unique, innovative, and game-changing ways to treat HIV, multi-drug resistant TB in the poorest places in the world. And that was really an astounding accomplishment, and for most of us, that would have been enough, except that Jim was a restless guy, and later he became chairman of Harvard's Department of Global Health and Social Medicine. He became president of Dartmouth College, and then he became president of the World Bank. And you might ask yourself, like, how did all that happen? I'm not sure I can tell you how that happened, but I think it's an amazing testament to an amazing person. In the 1950s, a philosopher named Isaiah Berlin wrote an essay called The Hedgehog and the Fox. And he sort of divided up all of us into one of those two categories. The hedgehog was somebody who knew everything in depth about a very small slice of the world. And the fox was somebody who wandered and knew a little bit about a lot of different things. I think I fall into that second category. I know a little bit about a bunch of things. But I think Jim really defies that because he knows an incredible amount about an incredible number of things. And that's allowed him to have these types of positions and to make a major impact in the world in so many different ways. I will say, this is my own observation, having known Jim for a while, that all these lofty positions, president of this, president of that, chairman of this, they're all connected to individual human being needs. And I think that's what's grounded his work in and made it so valuable over all these years. He never loses sight of the fact that at the ultimate outcome of these positions, there are human beings that are affected, whether it's the students at Dartmouth or the efforts of the World Bank or Partners in Health to reach and change individuals in the world. And for me, that's the glue that's connected so much of what you've done and been a great inspiration for me and for so many others. So Jim, I will just say after Jim's talk, we will hopefully have a few minutes for questions. Jim, thank you very much.
Thanks, everybody. It's just, it's really great to be here. And I have to say, being able to listen to the lightning talks, it's just so encouraging that we're continuing in very difficult times. And so the title of the talk may sound a little strange. In fact, I borrowed it from a talk on medical ethics that I gave at Harvard a few months ago. But I raise it because I think we've got to make the argument all over again. Why do we do global health? You know, when I started medical school, there were exactly 2 people in my medical school class who had any interest in what we called international health at the time. And international health at the time was mostly researchers going to get samples in poor countries, right? It really wasn't about care. The work that we started at Partners in Health was just so outside the mainstream of what people thought was a reasonable thing that academics could do. But to see all the stuff that you guys are doing, it's very exciting. So I'm going to go back. I apologize, it's going to be very biographical. But it's going to be very biographical because I was part of an evolution in human history that I think is truly remarkable, and that we're at the brink of losing so much of it. And so when we're at these crisis stages, I find myself going back to Martin Luther King. And this is one of the most important and not as oft quoted as some of his other things, but he said, and this was in Grosse Pointe, a very wealthy high school in near Detroit, "Human progress never rolls in on the wheels of inevitability. It comes through the tireless efforts and the persistent work of dedicated individuals who are willing to be co-workers with God And without this hard work, time itself becomes an ally of the primitive forces of social stagnation. So this is important for me because he talked about this, the struggle that he was going through, the civil rights struggle, as being a co-worker with God. And in my experience, Partners in Health, we've had people of every different religious, ethical, even atheistic background. And yet there was this common sense that we were doing work that had been embraced, at least in some form, by every major religious tradition. So for us at Partners in Health, it was the idea of a preferential option for the poor that actually came from Latin American Catholic priests. And interestingly, this term, preferential option for the poor, is now being used by Pope Leo, who learned it when he spent time as a priest in Peru. Right? So it's that, of course, that was very important for us. And for us, we felt like this idea of a preferential option for the poor protected us and guided us in such important ways. But in Judaism, tikkun olam is, many of you will know, is the idea of healing the world. In Buddhism, compassion for the suffering of others. Literally, compassion means to suffer with. And even in Confucianism, doing the right thing by others is central to a Confucian ethic. So we believe that the work of global health, and certainly we tried to make this a reality, is very much in line with all the great moral systems of the world, and the turning back that we're seeing is going against that. Now, I was part of this notion of human progress in a very personal way. So that's me when I was 3 years old, living in one of the poorest countries in the world. Right? So in 1959, when I was born, Korea was so poor that the World Bank refused to give loans to it. Now, the World Bank gave loans to everybody, but they thought that Korea was so hopeless that they didn't deserve to get a loan. And they said this: Korea would find it difficult without foreign aid to provide its people with more than the bare necessities of life. When I took over as president of the World Bank, my vice president of East Asia put a whole pile of papers on my desk, which were the assessments of Korea back in the late 1950s, early 1960s. And he wrote me a note on it, and it just said, "Funny how wrong we get it sometimes." Now, I'm going to come back to Korea in a way that you might not expect, but for me, in 1959, my parents were very fortunate because those who believed in human progress had identified my parents as promising young people and brought them to the United States to study. My father studied dentistry. My mother studied as an undergraduate in Tennessee. And they met completely by chance in New York City, married. My brother was married, my brother was born in New York City. They went back to Korea, and my sister and I were born. And so everything about our lives, first of all, both my parents were refugees. And so the Korean War affected their lives very deeply, but they found each other, they met. They were identified by, my father was American Army dentist that identified him as a promising student. My mother, through a women's organization in the United States, who gave 2 scholarships a year to students in Korea. So there was this idea that even in one of the poorest countries in the world, you can find promising people and you can bring them to study, and this is going to make the world better. So to fast forward, grew up, my father was a dentist, my mother did her PhD at the University of Iowa, and I went through school and I ended up here. I was very fortunate to get into an MD PhD program in medicine and anthropology at Harvard, and I met these 2 people, Ophelia Dahl and Paul Farmer. And Ophelia, when I first met, was just starting college at Wellesley, but Paul and I were in the same MD PhD program, and we talked long into the night. We were the 2 of the very few people interested in global health. I had just come back from doing my PhD in Korea, again, because I wanted to reconnect with that country. It was in the mid-1980s. And Paul asked me a very simple question. We were both MD, PhD students, and he said, okay, and he called me Jimbo. He said, Jimbo, let me just ask you a question. Given the ridiculously elaborate nature of our educations, what is the nature of our responsibility to the world, right? And it was a difficult question for me because I had thoughts about, well, I'm going to go learn Korean. I'm going to serve my community in the United States, Korean Americans. So it was a pretty narrow view. Paul, on the other hand, had decided to go to Haiti. Paul met Haitian migrant workers in North Carolina when he was a student at Duke. And Paul spoke some French, so he got to know them. And what he learned was that the cane workers in North Carolina from Haiti, the work was backbreaking. And part of the reason that he knew it was backbreaking was that one of the things that his father did was make him and the other kids actually do that work to make money. He knew it was backbreaking, but the Haitians who were there were so grateful for the opportunity to work there. And so he wondered, what is going on in Haiti? He went there in 1982, right after he graduated, and saw that the poorest country in the Western Hemisphere had just such incredible needs. As one of the great anthropologists of our generation, Paul learned Creole very quickly with the foundation of French. And he started doing just very basic healthcare programs. And the needs were so enormous that it began to grow. But when I joined Partners in Health, it was literally the day we incorporated as a 501c3, the budget for Partners in Health was about $75,000 a year. And it all came from one guy, this amazingly wonderful Catholic construction magnate named Thomas J. White. And he said, whatever you need in Haiti, we're going to do it. And so we had incredibly low aspirations. We thought, we're never going to have much money. There's no funding for global health. There was no Gates Foundation, no global fund. But you know what? We're never going to avert our gaze from the suffering of the poorest. And in this case, it was the poor of the Central Plateau of Haiti. The project began to grow, and we were invited at the same time. But the priest whose rectory Paul was living in when he was a medical student at Harvard invited us to go to Peru with him when he went there as a missionary. And Paul was, I don't know if we should go to Peru, but it might be a good experience. And let's look at situation of urban poverty as opposed to rural poverty, which is where we're working in Haiti. And so I went. I went as our sort of emissary. I didn't speak any Spanish, but I was intensively studying it. And we ended up in this community. It's called Caraballo, right? It's an urban squatter settlement on the northern cone of Lima. And this is where Father Jack Rusin, who was the priest who had the rectory that Paul lived in Roxbury, near Harvard Medical School, and he said, you guys should work here. It'll teach you something. It's different. It's a different kind of poverty. Now, Paul would point out that immediately you can tell that this place is so much wealthier than Haiti because look at the power lines. They actually have power in the northern cone. But then we ran into patients like this. In a town of 100,000 people, and Dr. Bisson, I don't know if he's still here, but such a different perspective on tuberculosis that I found fascinating. But this is a gentleman named Melquiades. And Melquiades came to us with drug-resistant tuberculosis. And we knew it was drug-resistant tuberculosis because I carried his sputum sample with me through the Miami airport back to the Mass State lab. And the reason I did it is I was very careful. I looked at all the signs in the Miami airport. It said, no food, no fruit, no meat. But I could never find anything that said no sputum. Right? So we brought the samples back. The Mass State lab, to their great credit, did all the resistance studies, and he had 5 drug-resistant TB. right? Because what we learned was that Peru had the best DOTS program, Directly Observed Treatment Short Course, the best TB control program in Latin America. They'd gone from 40 to 50% cure rates, all the way up close to 80% cure rates. And they were so proud of their DOTS program. But what we learned was that in Peru, if you fail first-line therapy, and first-line therapy is, at that time, was 2 months of 4 drugs, isoniazid, rifampicin, pyrazinamide, and ethambutol, right? those 4. If you failed that regimen, the recommendation, let me just ask this, medical students, are medical students here? No. Okay. But what do we learn? What do we learn about tuberculosis? What's the one thing that you never do if your patient is failing the tuberculosis therapy? Anybody? Never add a single drug to a failing regimen. Right? We learned about the development of drug resistance from tuberculosis. Streptomycin came out. It was effective against tuberculosis. We were so excited. We gave single drug therapy. Quickly, they developed resistance. So we know that that's the one thing you never do. You never add a single drug to a failing regimen, but that was the official recommendation of WHO. So the World Health Organization, their official recommendation for poor countries is to do the one thing that clinically you're taught to never do. So it was basically systematized malpractice. Now, I say that just so that you know what we were up against. But the people at that time who were running the TB world at WHO, they were good people, right? And they just made the assumption that the resources that they had at the time were all they were ever going to have. And they made the assumption that it's not ideal, but it's probably the best we can do given limited resources. Frankly, we were appalled. We were appalled because, Peru was a growing nation. They have a lot of natural resources. The economy was growing. We thought that we could do better. And so we scoured the world for access to some of the second-line drugs. But the reason the second-line drugs were so difficult to find and so difficult to get is because they were only used in wealthy countries. And these were all the sort of rejected drugs of the past, and rejected because they were weaker and they had more side effects. So we knew that the only way to treat patients like Melquiades was to put them on drugs like capryomycin and cycloserine and clofazimine, the leprosy drug, ethionamide, paramino-salicylic acid, an ancient antibiotic. And when we started, the cost for that regimen was $25,000, right? And so even our most generous donors were saying $25,000 per patient. Why would you do that? It's so expensive. And the people who are running the World Health Organization TB program would say, $25,000, it's not just that, it's so much more than that. How can you justify spending that much money on a single patient when it would treat so many people with just garden variety tuberculosis? But we found 50 cases in a town of 100,000 people. So it was essentially an outbreak, right? And so, the rate, Dr. Bisson would know, in the US is what, 7 per 100,000, maybe something like that. In Peru, it was higher. The rates were like 300 per 100,000. But we had 50 MDR cases identified by the Massachusetts State Lab in this town of 100,000 people. So we had to swallow hard and make a decision. We said, okay, if we start treating these patients, this is not just a fight for Caraballo. This is not just a fight for the 50 patients. We're going to be scrutinized. We're going to be criticized. We're going to have to be successful because this could open up the possibility of treatment for everyone in a developing country living with MDR-TB. So we started. And this is what we got. WHO policy. In developing countries, people with multi-drug resistant TB usually die because effective treatment is often impossible. MDR-TB is too expensive to treat in poor countries. It detracts attention and resources from treating drug-susceptible disease. So the head of the Peruvian TB program, Pedro Suarez, brilliant guy who built the best DOTS program, the best a general TB treatment program in Latin America. We went to see him. And what we thought we'd get was him saying something like, well, we really appreciate that you guys have so much compassion for these patients. And yeah, we can't afford to do it as a program, but why don't you go ahead and give it a try? That's not what he said. He said, if you treat a single patient for drug-resistant TB, we will kick you out of the country. Right? So there was anger. And in the TB community, which is a very tight-knit community, there was anger. It wasn't sort of a bemused kind of semi-support, but gosh, we really can't do it. It was anger. And what we were hearing was people essentially saying, who the hell do you think you are? If this were possible, we would have done it. What are you accusing us of? Right? So it was really, we were taken aback, we were shocked, but we thought, hey, we hit on something here. We're hitting at a nerve that could be important in the future for other diseases that are deemed impossible to treat in developing countries. So I had done my PhD dissertation on the drug industry. So I knew a little bit about how drug prices drop and go up. And at a meeting that we had at the American Academy of Arts and Sciences with all the TB community, I asked a very simple question of the leaders of the World Health Organization TB department. I actually knew the answer already. I asked them, so of all the MDR-TB drugs, do you guys know which ones are on patent and which ones are off patent, right? Because if they're off patent, they're artificially high priced. You can bring the price down very quickly. And when I asked them if they knew which ones were off patent and on patent, they all looked at me and said no. So these guys had declared a death sentence on everyone living with MDR-TB in a poor country and never checked whether or not these drugs were on or off patent. So I told them, they're all off patent except the fluoroquinolones, right? And they were kind of surprised. And they said, well, what does that mean? I said, it means that we can probably drop the price as much as 90% very quickly. And that's what we did. We created a committee. We created a committee that would monitor the use of these drugs so that we didn't develop pan-resistant organisms. And we dropped the price by about 90% on average. And this was like 3 months, right? This was MSF just going to India and China and saying, hey, can you guys make these drugs? Eli Lilly was the only company making cycloserine and capreomycin. Capreomycin is difficult to make because it has to be fermented. Eli Lilly stepped up and said, okay, we're going to help you guys. They went to China and gave the technology for making capreomycin to a Chinese drug company, and we then had much lower priced capreomycin. So I say this because it was just a shock after shock after shock. How can you declare a death sentence while not knowing these basic things? And it's because the patients who are suffering under this policy are not in a position to object. Now, this is Melquiades, and we put him on very difficult treatment. And there's a movie, actually, that features him. It's called Bending the Arc. It's on the Partners in Health website, www.pih.org. And it's a movie that really highlights him quite a bit. So I didn't meet Melquiades again until about 10 years later, when we had our World Bank IMF annual meeting in Peru. And they brought him to meet me. I was president of the World Bank at the time. And this is what he looked like. He'd become an accountant. In the movie version of it, I went to see him when he was at his worst, and he looked like he was going to die. Right? And I don't know, what his parenchymal damage scores are, but he's doing pretty well right now. Right? So we thought, okay, that was really cool. And we were able to change policy. It was like it was 2001, I think, that they finally got rid of the so-called the second scheme, esquema dos in Peru, where you add a single drug to a failing regimen. They got rid of that policy in 2001, and we thought, wow, what's next? And around that time, of course, in 1996, we had the highly active antiretroviral therapy, and I show you this picture is because, you know, the activists, the AIDS activists, were among, I think this is one of the most astounding movements in the history of the United States. It's just unbelievable what they were able to do. They were able to change FDA policy. They were able to change the speed at which drugs come to market. They put their bodies on the line to be tested. They did so much amazing stuff, and they pushed and pushed and pushed until we got the drugs. And at the time that we developed the antiretroviral therapy, which is around 1996, most of the activists dropped out. But there were like 5 or 6 or 7 really committed people who said, Eric Sawyer, Greg Gonsalves, people who became very good friends, they said, we are not going to let these drugs be only used for rich people. We put our bodies on the line for this. We are going to take the movement that we started for drugs in the United States and take it to the rest of the world. And so, you know, it's hard to really give young people a sense for how this worked. You know, Glenn will remember, Larry will remember, 99.99999% of all physicians believed that it was impossible to treat HIV in Africa. Right? And the consensus was extremely strong that it's impossible to, it's too complicated, you can't do it, there's no, you know, supply chains, blah, 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 blah. The story went on and on and on. Luckily, there was one person who didn't believe that, and that was Tony Fauci. This is the testimony of Andrew Natsios, and this is Tom Lantos, who is a supporter of HIV treatment in Africa. And this is Andrew Natsios, who at the time was the head of USAID, and he was testifying before Congress, and they asked him a question, can you treat HIV in poor countries? And here was his answer.
If you've traveled to rural Africa, you know this. People do not know what watches and clocks are. They do not use Western means for telling the time. They use the sun. These drugs have to be administered during a certain sequence of time during the day. And when you say, take it at 10 o'clock, people will say, what do you mean by 10 o'clock?
So for my African friends in the audience, so he had just visited South Africa, right? And the people who hosted him in South Africa said, well, we heard his testimony, but we can tell you that the only one who was late for every meeting was Andrew Natsios. Now, you know, we can laugh, but Andrew was not a doctor, right? And he was trying to give his personal spin on what the physicians at USAID were telling him. No, 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 there's no way we can treat HIV. It's, again, they said it's too expensive. The drugs were $12,000 per person for a year. There's no way you can do this. And we were sitting there saying, okay, there are 25 million people living with HIV in Africa. So you're really gonna tell them, sorry guys, it's just too inconvenient. We think it's just a little too expensive. You're all dead. How could you do that? And so a lot of things happened. First thing, the Tony Fauci story, right? So Tony Fauci was a good friend of ours, and he was very supportive of the work we did at Partners in Health. And Tony put it this way, which is exactly what you'd expect Tony to say. Tony said, look, I don't know how to treat HIV in Haiti, but if you tell me that it's doable, of course, I worked so hard to get these drugs to market, I support you. And so he took Paul Farmer to the White House in, you know, late on in an evening in November, along with people like Peter Mugenyi, the great Ugandan physician who started treating people with HIV. And they went and met with the top aides of President George W. Bush. And Paul showed this picture of Joseph Jun. So Joseph Jun came to us suffering from both HIV and tuberculosis. And just a few months later, looked like this, right? Now, later, we brought him, Joseph Jun, to the Toronto AIDS meeting, right? We brought him. And the Partners in Health team was walking around, and there was a poster from Kenya. And it had Joseph Jun's before and after picture on the poster from Kenya. And so the Partners in Health team came up and said, that's Joseph Jun. He's from Haiti. Oh, no, he's from Kenya. Right? He's a patient at El Doret, and he had, they knew everything. They said, no, that's a Haitian patient. That's Joseph Jun. No, El Doret. And so they brought Joseph Jun to the poster, and they said, you see, here he is, right? And so the Kenyans, they had got these pictures, and the people who were presenting didn't know whose pictures they were. And so they started crying, they hugged him, they took pictures. And the reason that happened is because we put Joseph Jun's before and after picture in the World Health Report, right? And something happened. We created something called the 3x5 movement. I ran the campaign of the guy who won the election to be Director General of WHO. It's a fellow Korean, a very good friend of mine. And he won the election, and I told him we're gonna change the way WHO does things. Instead of arguing about whether treatment is possible or not, we're just gonna set a target. So in July of 2003, we set a target to go from, in Africa, there were probably 20 or 30,000 people getting treated. We said that between July of 2003 and December of 2005, we're gonna get 3 million people on treatment. Right? And so we started running. We were doing all of these things to make it possible. And one of the things we did that was, I think, the most important thing we did was we created a global FDA. We created a system inside the World Health Organization that would give quality information on generic antiretroviral drugs, right? And so we just basically said to the research-based pharmaceutical industry, sorry guys, but the fact of the matter is you only get 1% of your profits in Africa. So we're gonna go forward with generics because people need it for life-saving treatment. But even then, when this is after George W. Bush declared that he was going to treat HIV, that far. That happened after Paul's meeting with them. Even after that, there was just so much hesitancy about whether to go forward or not. So it was essentially saying, this looks like a chess match. We're just going to throw a bowling ball on it. We're going to set a target, right? So we didn't meet the target. But we met the target 2 years later, in 2007, which I think is the best that WHO has ever done on any target in history. And by the end of 2005, we had more than 1 million patients on treatment. And I remember my goal was to go out and sort of convince people that we can do this and that we have to do this. And what I would say is, look, we have medicines. We now know we can make them generically. And with the help of President Clinton, we brought the price of antiretroviral drugs from $12,000 a year to $70 a year. And because we could mix and match the drugs, we created fixed dose combinations that you didn't see in the developed world because they were made by different companies. Fixed dose combinations, 1 pill in the morning, 1 pill in the afternoon, and the results were amazing. And so from a starting point of Andrew Natsio saying Africans can't tell time, right? We got 1 million people on therapy. Of course, many of you know the story much better. But now we have 6-month injectable PrEP that could change the story. But it's not going to come easily. I think we're back at a time when we're going to have to, and I'm doing this right now, talk to the activists again. I think we need to do something that is going to recreate some of the energy that allowed us to get to all these people on therapy, almost 30 million people on treatment in Africa. And I tell you, I went there, I went and talked to people at a time when I was, in my speeches, I was saying, look, let me tell you, 25 million people in Africa living with HIV. If we turn our backs on them, we will always be remembered as a generation that stood by passively as a genocide happened right in front of us, right? That's the kind of language I had to use. All right, so all these great things happened. Human progress didn't roll in on the wheels of inevitability, but there was amazing progress. We had $20 billion a year. And before we had, maybe a couple hundred million. And so what I thought in my head was, it's like the dog caught the car. The dog's been yap, 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 yap. You got to treat HIV, you got to treat HIV, and boom, we had $15 billion. So what do? So we tried to create something called global health delivery. And there are now many global health delivery programs. I don't know is there anything like that here? I don't think so, right? Global health delivery, meaning we've got to figure out ways of helping everybody do this very complex intervention. And now we're still doing that. So through all that, I had this crazy experience of being asked to lead Dartmouth College. And I've told this story a lot, but when I met the headhunter, he interviewed me for about 3 hours, and he said, Jim, you're an interesting guy, but there's no way you're going to get this job. So I didn't really want the job. They came to me, and so I said, okay, right? But then he called me back, and he said, I have no idea why, but they want to meet you. Right? So I did what my mentor, Howard Hyatt, former dean of the School of Public Health at Harvard, told me to do, which is, anytime somebody asks you to look at an important job, you have to study it, you have to think about it, and you have to do everything you can to give them your vision of what to do. And I was reading about Dartmouth, and Dartmouth was thought of as such a conservative campus, but I came upon a speech that one of the presidents had given in 1946. He had just come from working in Franklin Delano Roosevelt's State Department, right? John Slondicky. And so the board asked me all these questions, and at the end they said, okay, so Jim, why do you want this job? And I told them, look, I've never wanted a job like this. But you guys remember what John Slondicky said in 1946 at Convocation? Of course, nobody knew, right? But he said this. He said to the incoming students in 1946, he said, I just want to remind you of two things. It's fresh from FDR's State Department. He said, first, I want you to know that the world's troubles are your troubles. And that's like, wow, saying that in Hanover, New Hampshire, the world's troubles are your troubles. But because the worst troubles of the world come from within the hearts of men, and there were only men at Dartmouth at that time, come from within the hearts of men, there's nothing wrong with the world that better human beings cannot fix, right? And so I said, look, I'd never heard of a mission statement like that before. So if what you want me to do is to nurture the better human beings that will tackle the world's troubles, I think I can do that. So these captains of industry, these famous people who are on the board of Dartmouth, they had tears coming down their eyes, right? And then I got the job. And the headhunter was probably right that I wasn't right for the job, right? Because I was a troublemaker. You can't be a troublemaker and be a president of a university. I still have deep, deep love for this institution. I learned so much from being at Dartmouth. But it led to, on a Monday, I got a call on a Monday from Tim Geithner. And Tim Geithner at the time was a class of '83 of Dartmouth, a friend of mine I met through Dartmouth. He was Secretary of the Treasury. And he said, hey, Jim, how'd you like to be president of the World Bank? And I said, Tim, I was the lead editor of a book that called for the closing of the World Bank, right? And he said, I know. I said, well, have you read it? Yeah, the people who vet people, they read every word of it. And it's still okay? He said, yeah. I said, can you come down and see President Obama? I said, when? He said, how about tomorrow? Right? Which means that I was like at the end of the list, right? Because they were getting desperate, so that I was at the end of the list. And so I went to see President Obama, and I walked into his office, and he looked at me and he said, so Jim, why should I nominate a physician and an anthropologist to be president of the World Bank? Why wouldn't I, nominate a macroeconomist, say? And so I said, well, President Obama, have you ever read your mother's PhD dissertation? Right? And he looked at me and he said, well, yes, I have. Right? Now, I would bet that he's like the only president in the history of the United States who would have read his mother's PhD dissertation, right? But I said, okay, so then you'll know that she worked with Indonesian artisans, Indonesian metal sculptors. I said, well, you'll know that she showed that while the macroeconomists predicted that globalization would wipe out the Indonesian artisanal industry, she showed that it flourished, and Indonesian sculptors started selling their goods everywhere. I said, I'm not going to be able to tell you what the world looks like from 30,000 feet like a macroeconomist, but I've been on the ground doing development work my whole life. I'm going to be able to tell you if these programs are working or not, right? And so he looked at me and he said, I get that. Next day, we were out in the Rose Garden. He was nominating me, and I don't think there's any other president that would have nominated me for this job. But I was, benefited a lot from the fact that his mother actually did a PhD in anthropology at the University of Hawaii. Right? So, what an amazing opportunity. This is what you see when you walk in the door of the World Bank. Our dream is a world free of poverty. What an amazing mission to take on. And the position is ridiculous. You're like a head of state, so you get in pictures like this, right? And so this is like one of the first pictures I've taken. I didn't get the memo that you're supposed to wave when this is the so-called family photo, and you can see President Erdogan from Turkey. He knew, man. He did both hands. He was. But one of the great privileges of this is that you see these people, 2 or 3 times a year, and you're in these meetings. We worked so closely with Chancellor Merkel on climate change-related stuff. It was an amazing experience. And the one thing I think I left behind was toward the end of my tenure, I asked our team a very simple question: What does it mean to improve health and education outcomes, and does it have an impact on economic growth? And what they found was that improvements in specific outcomes in both health and education were the strongest predictors of economic growth of anything we'd seen. So we said, here's what we're going to do. We're going to measure these outcomes. It was, under 5 mortality, childhood stunting. We had this measure called learning adjusted years of schooling, so we could compare the quality of education across different countries. And so we started ranking countries. And now, now 2 World Bank presidents later, this project is still going strong. And we're now telling countries, you really want to grow your economies, invest in health and education first. Now, I'm going to leave you with this particular story because it's such a difficult one. Human progress happened in Korea almost unlike any other place. I mean, China's the only other story where it happened so quickly. But Korea went from one of the poorest countries in the world to one of the largest economies in the world. But human progress in this case wasn't just, you can't stop at economic development and technological sophistication, because human progress means much, much more than that. And what Paul Farmer used to call it was accompaniment. That accompanying people, being with people, being there for people, being connected to people is also a critical part of human progress. So Korea has developed so much, but the suicide rate's the highest in OECD. Only behind 2 or 3 very poor African countries in terms of suicide rate. Depression, symptoms of depression, and if you compare the symptoms of depression with treatment, you can see, let's see, yeah. So in terms of the number of people getting treated, right? Korea has the lowest treatment rate for depression and the highest estimated rate of depression. So something is going on here, and all of this condenses down to the lowest fertility rate ever recorded in human history. In 2023, 2.1 children per woman is the number you need to recreate the society. In 2023, Korea was at 0.72, 1/3 of the population replacement rate, right? And so I looked into these because the president at the time of Korea asked me to help him with this. And so it just illustrates something I think very important, which is that human progress, again, is not simple. It's not just economic growth. It's not just technological sophistication. It's about how connected we are to each other. Emil Durkheim, the great sociologist, wrote a whole book on suicide. And he said that high suicide rates are a sign of social disintegration. And unfortunately, this is what we're seeing. Korea has had moments of incredible national cohesion. This was when they made it to the semifinals of the World Cup. But the most amazing story that I'd ever heard was that in the late 1990s, at a time when the economy was just crashing, the Asian financial crisis, Korean people came and donated all their gold to the central bank. And they donated more than $3 billion to the central bank. And it had a very strong impact on their ability to come out of the Asian financial crisis. So there is a possibility. There are things you can do to recreate national cohesion, and that's what they face. Right? So again, this is a very painful story for me to look at, but it's happening everywhere. Even India, for the first time last year, their population went down. India now is not at replacement rate yet. So this is the next series of problems. It's not as sort of, I think, morally easy to take a side on as HIV treatment in Africa, but it's also part of what we have to be concerned about. And there was a wonderful presentation on aging, something that we have to be concerned about as if we're truly global in our global health. So I'm going to leave you with a couple of lessons that I've learned throughout this process. Right? First, find the best possible partners. I was so lucky to find Paul and Ophelia and so many others. And then now we've built it up with so many people who join Partners in Health and the whole world that we created around them. And nurturing them, working with them, learning from them, it's a huge part of what you have to do. You have to think about this very deliberately. Seek out great mentors, but more importantly, learn how to be great mentees. I've had a leadership coach for a long time, and he wrote a recent book called Becoming Coachable. Right? So the secret to having a great mentor is to understand what it means to be a great mentee. You have to prepare for your meetings with your mentors. You have to really try to help the mentor give his or her best to you. You can't get everything from a single mentor, I don't think, but find them. I had just the greatest mentors. Larry has been one of them. But, Arthur Kleinman, my anthropology professor, Sally Faulkner at the anthropology program. I had so many. And I continue to this day to seek out mentors, even at my late stage in life. Work on your leadership skills, right? Leadership is about humility and listening, right? And as I told you, I've had this leadership coach now for like 13 years. And he gives everybody the so-called feedback. He does a 360 interview with all the people that you work with. And he's known as, Marshall Goldsmith is his name, he's known as the most celebrated, the most accomplished leadership coach in the world. And he gives you feedback in a way that is so devastating. And I would say, after he told me this stuff, I said, okay, Marshall, look, I was thinking that, but I was sure that no one knew I was thinking that, right? And getting that feedback is so critical, and you have to keep getting it, and it's the most humbling thing that you can possibly do, but it's the key to success on any level, right? Non-negotiable in areas of moral clarity. These are Paul Farmer's words. We used to say, you gotta be clear on what you really believe. And for us, it was the notion of a preferential option for the poor. This is why we were so grateful to have Larry build out the global oncology program at Partners in Health. There's literally nothing that we're gonna turn our backs on if we believe that it's a good thing for the poor. So this is something that's been quoted a lot now, because I came up with this sort of at a dark moment, right? If you're a global health practitioner, optimism is a moral choice, not the result of analysis, right? Because with tuberculosis, drug-resistant tuberculosis and HIV, the result of analysis was the conclusion that it's impossible to treat MDR-TB, impossible to treat HIV. And if you're a University of Pennsylvania elite medical professional or a scholar, and you go to a very poor country, in Africa, Southeast Asia, wherever, and you say, it's hopeless, that's the outcome you're going to get. That's the outcome you're going to get. And so finding your path toward optimism is serious work, and we all have to do it. So for now, what do we do? Human progress, what do we think? So I think you just have to be patient. Sharpen the saw, that's Stephen Covey's great saying. There are times when you just have to step out and work on developing new skills. So it's not bad to be in a master's program or some other program where you're developing new skills. But if there's only one point that you learn from this, I want you to know that the struggles we're facing today are not as severe as having the head of USAID say that Africans can't tell time. We've faced this before, but it's going to take the kind of commitment, the kind of courage that we had to have as we tackled these problems in the past. But we've done it. Martin Luther King did it. Martin Luther King, he was against something that was just so much more severe. And there are some people, authors, who will say, well, America is a country that does everything wrong until they finally end up and do the right thing. But the thing is, people of privilege can wait until that happens. But those of us who are serving the poorest people in the world, we can't wait. We've got to think about how we can do it again, right? And so I tell people now, at this point, Larry was so generous in saying that I have deep knowledge in areas. I tell people, look, I only have 2 skills left at this stage in my career. It's scheming and plotting, right? Right? That's what we need to do. And we need to do it with the people who created that revolution in the first place. I think we took for granted that we're going to have this support for global health. But what you guys are doing today is, I've heard so many global health talks, but it's so encouraging to me that you would tackle such specific issues in places like Botswana, that you would continue to do your research to try to gain more knowledge about how to tackle a wide variety of problems. This is human progress in its greatest sense. Now, I'll leave you with this. I'm sorry I went over time, but maybe not too much. This is what I was visiting in Tanzanian school, right? I was visiting in Tanzanian school. And I always do that, and I always ask them, what do you want to be when you grow up? So this boy raised his hand, shot up, stood up, and he said, I want to be president of the World Bank. Right? Now, along with this theme of human progress, the president of the World Bank in 1962 may very well have gone to Korea to see if maybe finally Korea is ready for a World Bank loan. And I don't think that if he had come to my kindergarten, he would have looked at me and said, hey, there's one of my successors in the audience. So what I told them was, never, because everyone in the room laughed just like you guys. All the teachers laughed, everyone laughed, right? I said, wait, I was born in one of the poorest countries in the world, and there's no way that if David Woods had come to Korea, that he would have seen that. So don't tell people that you can't do things. And again, human progress never rolls in the wheels of inevitability. You guys are doing this work, and if I can borrow from Martin Luther King, you're co-workers with God. You're doing the right thing. You're doing the needful. You're doing the thing that I think seems to be very exciting to you, but it's the path toward human progress, and I believe in that. Right? I'm not a relativist in that sense. Right? I benefited from it. My whole life was shaped by this idea that human progress is possible. So you have given me a great gift. You've given me hope that we're gonna get past this, and let's do it together. Thank you.
Now, I expect when this symposium is over later this afternoon, you will all go out and get to work.
And take your clothes off, block the streets.
So we are a little bit over time, but maybe we have time for one or two questions.
Hi, my name is Yong Kim. I'm a medical oncologist here. I just wanted to say thank you so much for that inspiring talk and sharing your journey and reminding us of what's possible. I just had a question about the current sort of global mechanism of financing for global health. So we know that USAID was dismantled. There is threat to WHO leadership, and the Gates Foundation is planning to phase out in 20 years. And so I was just wondering, what do you think, or which mechanisms do you think will fill some of these gaps? Because I think as much as a lot of your story has been inspiring, a lot of it has been driven by the financing, not just political support, but financial support for some of these initiatives.
So there are so many really important people, really important donors in global health that we didn't have any idea of before. So the MasterCard Foundation is one. The Gates Foundation has been great, but the Buffett Foundation could be even bigger, right? For the University of Global Health Equity, the donor was a guy who was a real estate person, but who started off selling the syrups that are used for juice in dormitories. And his whole history of giving was in 3 counties in Massachusetts. And he's now given, I think, $120 million for global health projects in Africa. So I think there are other people that will step up. I think the real sort of rethinking we have to do is about USAID, right? So USAID, unlike the Nordic countries or Canada or the UK, there is a very strong desire among the people of those countries to keep the budgets of those organizations. This is Swedish SIDA, this is NORAD, this is all the Canadian organizations, DFID. They have strong support from their people. And those organizations work on generating even more support among the people of the United States. That's not what we did with USAID. What we did with USAID is to say, and most of the money will come back to you anyway, right? So the Iowa senators and representatives are huge fans of USAID because USAID buys all their surplus corn, right? But when USAID buys the surplus corn and drops it in a country, that destroys the local farmers market. So, but there's, every leader of USAID has said, of course that's terrible, but unless we keep the support of the senators from Iowa, we may not, get our budget next year. So I think, a rising again of AID will have to be a little bit different, and maybe that's a good opportunity. So that's how I look at it. I think there will be others. I think that the work you guys are doing is just too compelling to turn back on, and I think things will get better.
Another question, go ahead.
We're in a time of war, and there seems to be a regression to tribalism. And what was very striking when you became part of Dartmouth was that you didn't come from that tribe that they normally draw the University of Residence from. So I wonder what lessons might you have for how to do better, or if you have any regrets to kind of reduce that tribalism or to be more effective for it?
It's a great question. As I look at Dartmouth, so just let me give you an example, right? Just one quick example. I told you leadership is so important, right? And leadership just kind of rubs faculty members the wrong way, right? And so 2 fantastic board members at Dartmouth told me they were going to give me as much as $50 million to create a leadership program for undergraduates at Dartmouth, right? So I was excited. I went to the faculty and I said, hey, we've just got this offer to create a $50 million leadership program, right? The guy stands up right away and said, wait a minute. And so he said, we hate leadership. What do you mean we hate leadership? Well, leadership connotes followership, and we teach our students to think for themselves. right? So I thought, okay, this is a little bit different than what I expected, right? And so, being a university president, what they say is that it's like you're in the Sahara Desert in a tent with 4 poles. And the poles are students, alumni, faculty, and staff, right? If one of those poles is up, you're okay, right? If 2 of those poles up are up and not working as they should, you're in trouble, but you're still okay. Once the third is gone, you should just get another job, right? And so each of the 4 poles, they have completely different ideas about the purpose of a university. And they have completely different ideas about what my job was supposed to be, right? So that's the hardest thing about university presidency. I mean, it's never been harder than it is right now. It's the hardest job in the world right now. But for me, I still like watch Dartmouth football games. It got in my blood somehow. I love the institution, right? But you're not supposed to do things as president. You're supposed to convene. You're supposed to support. And I think that was the problem for me, that I was too much of a sort of doer as opposed to a convener and supporter, which is what's needed. So lessons from that for today, I think that it's back to it's back to scheming and plotting mode, and not sort of trying to keep the waters calm. I think we need some roiling of the waters right now.
We all need to do that.
Yeah.
Right? Thank you.
Thank you. Oh, thank you.